What I've been asked is to talk about what do we know about ceramics, and this is fairly easy probably, but also what we don't know about ceramics, and that is going to be much more demanding. Eventually, I will try to reply to these three questions. My personal experience with ceramics started at the mid-80s, but the results and the data I'm referring to are only from 1990 to 2013, because that is the period of time that has been registered by our institution registry. We have also a regional registry that started in 2000s, and some of the data that you will see today are referred to these more than 50,000 SIPs that are reported during these 13 years. The Biolux Delta, that is the last development in terms of technology, is going to be started in our experience since 2007, and we have already more than 7,800 of them implanted. In our region, on the bottom, you see what we were using in 2000s. At the top, what we are using today in 2013. You see that the use of ceramics was only 18% in 2000s, going up to almost 70% in 12-13. Another interesting piece of data is that cross-linked poly was only 8% by then. Nowadays is up to 22%, leaving almost no space for metal-metal and very little space for standard poly. It's a matter of fact that around the world, the use of bearings is very much different. You see, these are some of the data are only referred to the country where we can refer to registry data. And you see that in our country, there is a lot of ceramics, or eventually ceramic, or eventually ceramic poly is more than half of our experience, while you can find some in Australia, but even less in the other countries. Some other countries, even Spain, the metal poly is playing the bigger role. So ceramic nowadays is not very widespread, and mainly it is spread around the world for use with poly. Now, this is how the 57,000 prostheses are divided. Just to take your attention, there are more than 23,000 ceramics. There are 4,600 metal, and all the other is about 22,000%. Now, let's see what is going on in terms of survival. We will compare, first of all, ceramics, metal, ceramic poly, and metal poly. This is standard poly, not cross-link. Well, the data are very clear. Ceramic is performing very well at the top of survivals, 94.7 at 15 years, while the metal and the metal poly starts dropping at 5 and 10 years. You see that even with ceramics to standard poly, we have a lower results, even if ceramic head versus standard poly is much better than metal, cobalt chrome to standard poly. So this is a first piece of data. Ceramic is performing very well. Standard poly is performing roughly well if you are using ceramics as a head, and metal is not good as the others. Now, if we compare the data with cross-linked poly, either ceramic or metal, you see that there is almost no difference at 13 for ceramic cross-linked poly to 15 for the other 2 years follow-up. So this is important. Up to 15 years, we can use ceramic or metal with cross-linked poly, and we should reach almost the same results as ceramic. Eventually, something could happen beyond 15 years, but this is still to be demonstrated. Just to let you see in more closer detail the comparisons between cross-linked poly and standard poly, you see that the cross-linked poly, as you've seen, is much better, and you can see that if there is a difference in terms of ceramic poly versus standard metal poly, no difference there is if you are using ceramic or metal with cross-linked poly. In our experience, in our regional registry, you see nowadays the top used bearings is metal cross-linked poly in terms of soft bearings. On the other side, we have also a vast majority, as you have seen before, of ceramic. The problem now is referred to demanding patients, or what we are going to apply, larger, wider articular range of motion, low wear, so we need prostheses that should have big heads beside hard bearings or cross-linked poly, eventually with vitamin E. Now, we know that with big heads, we had some problems. Even though we must be very careful, this is the same prosthesis, so same cup, same surface in terms of heads, but you see that the level of serum into the blood, the level of cobalt in the serum of these patients is 3 times more if you are using a stemmed prosthesis. All the articular part is the same, just changing the stem. Actually, what we've seen with the stemmed prosthesis, not the resurfacing, is that the larger you have your head diameter, the most severe is the rate of revision. And this is due, as we well know nowadays, to the problem of aseptic lymphocytic vasculitis or adverse reaction to metal debris that can lead to devastating necrosis around the articulation. On the contrary, the BHR, that is one of the best performing resurfacing, in our experience, even if we have low numbers, small numbers, is performing same as the other stemmed prosthesis. So we have not to fear just large diameter head alone, but large diameter head on a stemmed prosthesis. Different is if you are using ceramics. You see, this is what we have seen before, 28, 32, metal, no problem. Then if you go up and up in diameter, you have up to 22% of revision at 5-7 years. But if you are using ceramics, even the Biolox Forte, there is no difference, no significant difference between larger head, larger means 36 millimeter and upper, versus the 32. On the contrary, with the delta, this difference is even lower. So it seems that if you are using ceramic larger heads, you do not experience this problem. And actually, this is what we find at revision. This is after 8.5 years, almost new, and this is only after 3.5 years in terms of damage of the trunnion, and damage of the trunnion means production of debris, and even worsened if you are using adapter sleeves, and this means trunnionitis. That is a new path to failure, as we have seen with alval syndrome. So if you do want to use larger head, you could safely or more safely use ceramic rather than metal. Eventually, we recommend with very large diameter to use the adapter sleeve in titanium, because this enhance and enlarge the conical ratio between the head and the stem from 12-14 to 16-18, reducing the torque problem at the interface. Now, this is, on the contrary, what we are experiencing if with cross-linked polyethylene, either ceramic or metal, we are comparing the data with 28 or 32 versus 36 or larger. You see that after 6 years, the two curves starts dividing. So this is not, I want to underline, yet statistical significant due to the numbers, but this could be a red light that open on this material in terms of cross-link resistance to wear or to revision with larger heads. So if you want to use large heads in terms of reducing dislocation or other, I think that we have to be very keen in choosing the material, the bearings, because polyethylene may face with the problem of more wear, as we just see, or fracture risk, because cross-linking the poly is reducing the mechanical strength. Besides, if you are using larger head, you are also using thin layer in the liner. We know the problem with cobaltism and alval, with the metal. So I think that nowadays, the best solution in terms of reliability in young patients still is ceramic due to what we have seen until now. Now, what we don't know. Well, probably many things we don't know. I don't know even what to talk about. But this is probably some of the concerns that surgeons still have about ceramics. Are they still so fragile? Do they break so much? Well, if we take a look of the ratio of revision due to chipping or breaking of the liner, we see that with big numbers in our experience, we can show that the risk that was already very low before with Bilox Forte now is almost none, 0.1 with Bilox Delta. And we have also to take a closer look to why this liner eventually breaks. Well, the reason is mainly surgical mistakes in terms of liner malpositioning or anteversion or retroversion pathological way of the cup. Clearly, the problem is that in terms of damage due to instability as a consequence of the mistaken placing of the cup, what we have to do is the only possible way to change the cup, change the position. But we have to pay a lot of attention also to the post-op film. If we end up after the surgery with a liner that we see not well placed, even if it is by Delta, we have to be very keen because it may happen like this. This is March 19, this is May 29, just little more than 2 months, and the liner break apart. So our suggestion is if you have this in the post-op film, go back and fix it. What about the heads? Once upon a time, we know that the heads could experience some failure. Actually, we had up to 2% with the old, I would say nowadays, old Bilox. This rate was reduced to 0.3 only in 28 millimeters by Bilox Forte. Nowadays, we have thousands of delta heads and no fracture at all. And when we are talking about so many prostheses, so many heads at 10 years and even more, that is a problem solved. I don't think that the failure of the delta head is a problem anymore. Then we have squeaking. We have different squeaking. We have clicking, popping, squeaking. They are all different because they have different causes. We are making a very deep study about noises. We are studying the length of the noise, the frequency of the noise, and the amplitude of the noise, and we can differentiate them fairly well. And we have also a study going on right now in studying the ultrasound part of the sound. That is also characteristics. The other way we are experiencing that the clicking is mainly with the 28 millimeter head, almost none with the other. Why? Well, because the clicking is due to microseparation. And the smaller is the head, the higher is the incidence of a small dislocation or microseparation, as it is called. That is the cause of this noise. But anyway, what we find when we make a revision of squeaking hip is no macroscopic damage. We have seen reports of very high incidence of squeaking, but mainly because they were dealing with prostheses with a lot of impingement between metal and metal, and this was producing a lot of metal debris. Why this is important? Well, because actually the cause of the squeaking may be the third body particles that violates the fluidic film, making the squeaking. In our experience, only 0.5% of patients are experiencing some hip noise related to the prosthesis, never with delta. Last thing is, well, we have chromium inside the alumina or inside the delta. Isn't this leaking chromium ions into the body? Well, to make a long story short, we can say that no. This is patients with the prosthesis, this is normal control, no difference in blood, in serum, in erythrocytes, in urine. They are perfectly the same. So in conclusions, the facts. Osteolysis with ceramics is over, and this is a fact. The head fracture rate is nowadays close to 0, as we have seen, especially with delta. And the liner chipping is 0.1, and hip noise is 0.5. Bigger head ceramics are safer than other solutions, as we have seen. Survivals are at the top, even though I must say that from 13 to 15 years follow-up, they are tied by the cross-link, with the only exception of larger head. Ceramic bearings do not leak chrome ions, and I think that nowadays we have to think in bearings in terms of life expectancy and activity of the patients. There is not the perfect prosthesis. We have to adapt what we have to what we are dealing with. Probably with some old patients with short life expectancy, metal poly is still enough. We have seen that there is no difference up to 7 years. But with a very young man that needs a large prosthesis, large head prosthesis, ceramic is probably only the best choice. Thank you.